let me know. A very good evening to one and all, and welcome back for another fortnightly dose of our anesthesia patient safety rounds. So, our incident rounds, specifically to speak, it is our 7th episode, and we're so glad to welcome back all the regular people that attend and also the new people attending. We have several experienced, anesthesiologists with us here today with their experiences and anecdotal, words of advice, which I'm sure will be very useful to us, especially the very young and newly joined anesthesiologists and residents also who are joining. With this, also, we'd like to congratulate Dr. Murli sir for his recent election achievement. Congratulations, sir, for being GC member. I'm sure you'll be doing wonders and take us further, especially in the realm of anesthesia and patient safety. Thank you also for this great opportunity, Sunil Pandya sir and Dr. Bala Venkat sir, for all these initiatives that you open up so much of doors of opportunities for us today. So with that, get started. We have two very enthusiastic speakers today who are really willing and ready to share about the experiences from a previous newsletter. So first up, we have Dr. Vishwanath Senapati. He's a senior consultant anesthesiologist at HIMS Super Speciality Hospital and Cancer Center in Bhubaneswar. And he'll be talking about how a tourniquet is not just a surgeon issue, but can also be related to us as well. And then up next, we have Dr. Atul Aman, who is an assistant professor in a trauma and emergency medicine center at AIMS Kalyani in West Bengal. So he'll be talking about improvised warming devices, and I'm sure everyone has probably dealt with this at one point or another. So with that, today at the outset, we'll get started, and I'll just hand over the podium to Dr. Vishwanath Senapati to start with this first presentation. You can go ahead and share your screen, sir. Dr. Senapati, you can go ahead. Dr. Senapati, are you there?
Yes, ma'am. Yes, ma'am.
Yeah. So please, you can go ahead and start your presentation.
Am I visible?
Yes, you're visible. You need to put on your presentation.
So, good
You're
evening.
not able to see your presentation. Just a sec.
Is it visible?
No, only your desktop is visible. Your presentation is not yet visible.
Just a second.
No problem.
Is it visible now?
No, we're still seeing only your desktop. Maybe you can stop sharing and then reshare the PowerPoint.
Is it now? Sorry.
That's okay, no problem.
Is it visible now, ma'am?
No, we're only still seeing your desktop.
Can I
Jamil,
rejoin? Yes, sir.
so it says you're paused screen sharing for me. So what I suggest is you stop the screen share, that button down there on Zoom.
And then reshare. It's okay. Or I think maybe you have to swipe with 3 fingers or something.
Ma'am, is it visible now?
Yes, yes, you can see your PPT now. Perfect.
Sorry for the glitches.
It's all right. Okay, go ahead, sir.
Good evening, respected seniors, esteemed colleagues, and dear friends. Before we begin today's APSA AR Round 7, I would like to take a moment to extend my heartfelt congratulations to our respected senior Dr. Murli sir on his emphatic election as a National Governing Council member of the Indian Society of Anesthesiologists. Sir, this remarkable victory reflects the immense trust and confidence that our fraternity has placed in our leadership. On behalf of the APSA family and everyone joining us today, we congratulate you wholeheartedly and wish you a successful, purposeful, and impactful tenure. We are confident that under your leadership, our profession and patient safety initiatives will continue to grow stronger. Congratulations once again, sir. With that wonderful note, let us begin today's APSA AR Round 7. Today, I would like to introduce the culprit. It costs less than 100 rupees. It has no battery. It never alarms. It never beeps. Yet, it had potential to threaten a patient's limb. In an era where we discuss ultrasound-guided regional blocks, processed EEG monitoring, advanced hemodynamic monitoring, and target control infusion, our blind spot today is a simple IV tourniquet. Today's talk is not really about this rubber band. It's about patient safety. So let's begin where every AR round begins. That is with a story. The case began like any other routine case. Tourniquet was applied, IV cannula was secured, flushed, dressing was done. Everyone moved on. The patient was positioned. The drapes went up. Surgery began. Time passed. The tourniquet disappeared. Not because it had been removed, but because it had disappeared from attention. It was hiding in the plain sight. Fortunately, someone looked beneath the drapes before harm occurred. The tourniquet was removed. The patient remained completely unharmed. And perhaps most importantly, the incident was reported. Now, here is the interesting question. Can I ask everyone to be honest? How many of us have ever walked away after a cannulation and suddenly wondered, did I remove the tourniquet? Take a moment, think about it. Thank you. The fact that many of us would definitely agree with me, it is not a sign that we are careless. It's a reminder that we are human. Any patient safety begins the moment we accept that good people can make mistakes. So what exactly was this event? The patient safety has its own language. Was it a near miss? Or was it a no harm incident? Or it was an adverse event? The difference seems small, but it changes how we learn. So where does today's case fit? This was not a near miss. The patient has already been exposed. The tourniquet had reached the patient. Fortunately, the harm did not. Therefore, this is a no harm incident. That distinction matters because a near miss teaches us interception. A no harm incident teaches us about resilience, whereas an adverse event teaches us about consequences. So the obvious question is this really such a rare event? At first glance, it may appear so. Interestingly, Despite the fact that millions of IV cannulations are performed every year in India, there is remarkable paucity of published reports describing forgotten IV tourniquets. Does that mean the problem does not exist? Probably not. It is more likely that these incidents are under-recognized or underreported, particularly when no patient harm occurs. And that's exactly why incident reporting initiatives like AIR are so valuable. This is what happens when incidents are reported and analyzed. A single patient safety reporting system in United States have documented more than 1,000 forgotten tourniquet incidents. Over 30% remained on for more than 2 hours. Some remained as long as 24 hours. And perhaps the most interesting observation was most were discovered by someone else other than the person who applied them. This tells us something important. This is not a problem of careless clinicians. It's a recurring system problem. So once again, the obvious question becomes, who failed? The clinician who forgot to remove it, or the system that never asked? If your answer was the clinician, your answer was only half right, because no doubt the clinician made the active error, but the system failed to intercept it. And that's where the human factors enter the story. We often tell ourselves, I just need to be careful. Unfortunately, patient safety science tells us that it is not enough. Look at our working environment. Production pressure to finish the list by the end of the day, multitasking, the cognitive overload, reduced situational awareness, communication failure, the limb hidden beneath the ribs. These are not excuses. They are the realities. And here is the idea. I would like everyone to remember, competent clinicians don't become safer simply by trying harder. I repeat, competent clinicians don't become safer simply by trying harder. They become safer by working in safer systems. So let's look beneath the surface. Once again, I stress on this point, human error is inevitable. Patient harm is preventable. So what we are seeing here is the tip of the iceberg, which is above the waterline. That is what we see, the forgotten tourniquet. Below the waterline lies the reasons. No checklist, no reminder, no verbal confirmation, no visual cue. People make active errors. Systems create latent errors. If we fix only the individual, the next individual will eventually make the same mistake. Patient safety improves when we identify both. Errors rarely travel alone. They travel through systems, and they only reach our patients when every opportunity to stop them is missed. Patients are harmed when multiple small gaps align. Any one of this layer could have prevented this incident. So what should our response be? Patient safety is not about blame. There are two kinds of culture. In case of blame culture, the questions are who forgot, who is responsible, punish the individual. Incidents go unreported in view of the fear of consequences. Whereas in case of just culture, the questions are why did this happen? What system factors contributed it? Console the human error, coach and hold reckless the behavior accountability. Incidents are reported and learned. I wish to emphasize just one point over here before we move ahead. AIR does not exist to count mistakes. AIR exists to prevent the next one. So what can we actually do tomorrow morning to prevent this to happen again? Fortunately, the solutions are simple. Bright tourniquet, immediate removal, closed loop communications, one final limb inspection before dripping, and perhaps embedding this into our existing WHO checklist. No doubt, these are very small interventions, but they have huge consequences. So if you remember nothing else from today's session, please remember these 4 questions and answers. What happened? What type was it? Why did it happen? And how to prevent it? If every AIR round answers these 4 questions, we have already improved patient safety. I will finish with one final thought. The tourniquet was forgotten. Fortunately, the patient was not. Every reported incident is an opportunity to protect the next patient. Tomorrow morning, every one of us will insert another IV cannula. When you do, I hope one simple thought comes to your mind. Is the tourniquet off? If today's discussion makes even one of us pause before the next patient is draped, then the incident has already protected another patient. That's it. Thank you.
Very good, very lucid presentation. I think you've made a lot of good points, Dr. Vishwanath. Thank you so much. I invite Dr. Hetal Kumar sir, who is the academic director of the Academy of Regional Anesthesia India, who's joined us here today. Sir, is there anything else that you'd like to add on or share with some experiences?
Yeah, thank you, Archana. It was a really very nice presentation, and you have suggested a very important preventive measure which should be followed whenever using tourniquet. But as it is written by someone in comment, Dr. Karuna Swami sir, don't use tourniquet. Use a technician hand as a tourniquet. So it is an age-old technique, and if you use this, you can prevent it. And I can think of another method which I am using many a times, like you can inflate the blood pressure cuff in your NIBP and simply put the IV cannula, which is going to be deflated very soon. So you can think of these different methods also to prevent this incidents. And if you are vigilant enough, if the tourniquet is, then IV fluid will not go in. So if you are vigilant enough, you can detect it early. That is what I can say.
Yes, sir. Point well noted. Would anyone else like to add anything? Murali sir, would you like to add something?
Yeah. So when we had this incident reported, when we were going through the newsletter, editing the newsletter, I found that it was actually a very brave thing to write about something so simple. You would say, as Dr. Jami will agree, it's a very simple error that you can think about it as a simple error. That yes, we left the tourniquet and we discovered it later, but nothing happened. But if we just extrapolate on the timeline and say, yes, if this patient had gone to the ward with the tourniquet, and if the tourniquet had stayed for a day, imagine the consequences. I would like to just share one incident which happened way back in UK when we were training about the acupuncture needles that we put for dry needling. So this patient had the needles and had asked the nurse to remove the needles, and there were 2 needles which were forgotten. The patient thought that these needles are left for treatment and went home with the needles and called back after a week to just check whether the needles have to be removed at some point. Now, luckily, they were just acupuncture needles which were in. And in this case, you can just say it was a tourniquet which was applied and it was there for 105 minutes. But if it's an elderly, frail patient with the tourniquet in place and the venous congestion that can cause the edema, which can subsequently lead to something on the lines of a compartment syndrome, you can imagine the consequences. So I think we do have senior anesthetists here. Dr. Kumar Swami sir has joined. He leads the team at Apollo Hospitals. Sir has actually highlighted that, yes, we can use a technician to hold. But again, if people do not have technicians, they have to resort to tourniquet, or in situations where we don't have anybody to hold the hand or any other area for IV cannulation, we might have to use tourniquet. And this is a very good presentation by Dr. Senapati highlighting various aspects. And I loved the fact about how you highlighted that the active error is caused by the clinician, but the passive error is caused by the system. So I would label this as a trapeze artist in a circus, right? If you have a net underneath, you will be able to jump higher. You will be able to take that risk and trust that person to catch you when you jump to the other side. You don't have a net, you will be always scared. So this AIR reporting, the system that we have placed to highlight the various aspects of improving safety, is probably going to help people set up those good nets in their own clinical practice so that they can fly higher, they can take better risks and do more complex cases. So that is my take on this. Kumar Swami sir, would you like to add anything?
Thank you, Murli. Thank you for asking me to comment on that. I remember about 10 years ago, I had put an epidural catheter for a knee replacement patient, and the patient went home with an epidural catheter. He came back after 10 days. Nobody from our department checked, nobody from the surgical team checked, nobody from the nursing team checked. Patient was also not aware that this has to be removed. 10 days when he came back, the patient was asking, so something is there in the patient. Do you think that has to be there till the patient, my knee is completely healed? Then somebody said from the surgical team saw why this patient is asking that, and then they checked that there is an epidural catheter was there. Then immediately they sent to the anesthesia department. Then we removed. Fortunately, no harm occurred. But no harm occurred is not an excuse for leaving the catheter. I just want to remind you. Thank you.
Thank you, sir. Anybody else who would like to say anything? Dr. Dheeraj has joined, and I can see Dr.
Hi,
Viral.
sir.
Yeah, would you like to add anything? This was about a tourniquet which was left behind just for IV cannulation, which was put, the anesthetist forgot to remove it, and we were talking about the safety of systems and how an anesthetist might lead to active errors, but the systems are the ones which lead to passive errors.
Sir, no comments now, because that is a basic thing. I think we have to make sure we need to check at the end of the case.
Yeah, sure. Thank you. Thanks a lot, Dheeraj. Archana, I think
Okay.
Abdul had, I think Abdul had a comment to make or something related to the app. Abdul, would you like to just say a few words at this point?
Yes, sir. Thank you. Thank you so much. All right. So this is air rounds number 7, and every air round after the discussions, we have some novel techniques that are being discussed based on the incidents that we discuss, right? We will not have those novel techniques shared amongst each other if we don't report, yeah? So obviously reporting is vital, and therefore I have shared the links to the app to be downloaded from the Play Store and App Store. And while we are enhancing our knowledge at the academic level, there is also my team, which is standby by around 8 o'clock, where we will be testing our servers. So we have around 61 attendees. I request everyone to register themselves on the app if you have not already. And at the end of the second session, or just before the end of this webinar, we will have around 3 minutes of time where we can, report an incident. We all know that we never have probably, any day which goes without an incident. It may be unlabeled syringe which is used, wrong drug because of the complexities that are there in the OT every day with various people of different seniorities, different expertise levels conducting a single case. So you can download, register yourselves. We have 3 minutes at the end. We want all of you to report an incident at the same time so that I can test the server at the back end. And if required, maybe I'll have to enhance the capacity of the servers. So it is vital. It's not possible at the same time to have such large numbers reporting at the same time. So request everyone to please think of an incident while the second case is being discussed, and we'll have 3 minutes at the end of this webinar. Thank you.
Thank you so much, Dr. Abdul. Okay, so while everyone's thinking on their own incidents that might have occurred, thank you so much, Dr. Jami. That was such a wonderful presentation. So now we'll move on to the next presentation. Dr. Atul, are you ready? So you can start to share your screen. And Dr. Atul will be talking to us about improvised warming devices and some of the hazards that can come of them.
Is it visible, ma'am?
Yeah, I'm just seeing your screen. Still, your PPT has not come up. We can see it now. So you can put it in slide share.
Yeah. Good evening, everyone. Good evening. Thank you, Dr. Vala Venkat sir, Dr. Murli sir, and Dr. Pandya sir to give me this opportunity to be present in front of you, sharing this incident report. And I would like to congratulate Dr. Murli sir uh, being elected the National GC member of ISA. And this is a true reflection of your hard work, selfless service, and your commitment and vision have always inspired us. And we believe that you will continue to take the ISA to newer heights. So, starting with the incident review, I am going to discuss the iatrogenic thermal injury from improvised intraoperative warming devices. I have no conflicts of interest and citations have been done properly. This incident was published in March 2026 in the APSA newsletter. So the improvised warming device, which was made by a glove filled with warm water in a patient of a critically ill patient of going on laparotomy who suffered intraoperative hypothermia and bowel perforation was there. The patient was in septic shock and there was in the OT there was no validated active warming device was present. So the glove remained unattended and it caused contact thermal burn to the patient at the site of application. It should have been prevented and the patient was already hemodynamically compromised, so the patient suffered the burn. So what are we going to learn at the end of this presentation? We will able to recognize the perioperative hypothermia risk and how improvised warming causes burns. We will identify the system failures and apply guideline-based warming practices. And we will be able to develop institutional prevention strategies, SOPs for our institution. So summarizing the incident, the patient presented with bowel perforation and septic shock and required an emergency laparotomy. During the procedure, the patient core temperature continued to fall, but because a commercial warming device with water-filled glove was applied as a competing clinical priorities, the device remained unattended. The burn was recognized only after surgery, and this was not a failure of intention, but everyone was trying to help the patient. It was a failure of the system surrounding the decision. So the timeline of the incident, the emergency laparotomy case was posted. Core temperature started to fall after some time. The improvised warming device, that is a glove filled with warm water, was applied. and the anesthetist was busy in other OTs also, so there was no formal handover. The prolonged skin contact caused the burn to the patient, which was recognized post-operatively. So we need to know the why does hypothermia matter to our patient? It has been known that hypothermia is one of the most common and most preventable complication of anesthesia and surgery. The consequences which we can face that these are coagulopathy, surgical site infection, adverse cardiac events like uh, arrhythmias, delayed recovery and drug metabolism changes, and shivering. So how the different compounding risk factors are converging into this case. The patient was already in septic shock, the skin perfusion and sensitivity was already hampered. Patient was in general anesthesia, there was no pain response, and the position was long and the OT was prolonged and position was fixed. So the anesthetist was already busy, the device was left unsupervised, and there was no handover given. So the unregulated heat source caused burn to the point of contact as there was no thermostat or shut off in the device. So every risk factor amplifies the next until injury became almost inevitable. Why patients become cold under anesthesia? We need to know the three-phase model. Phase 1 of anesthesia is redistribution, which is in the initial 30 to 60 minutes. After induction, anesthetic induced vasodilation redistributes warm blood to cooler peripheries, leading to drop in the core temperature. In the phase 2 of it occurs in 1 to 3 hours, and heat loss is continued via radiation, convection, evaporation. In phase 3, it is the plateau phase. After 3 to 4 hours, the thermoregulatory vasoconstriction comes into function and heat loss is prevented. Core temperature is stabilizes at a lower level. So what are the causes of intraoperative hypothermia? The patient factors like age, comorbidity, septic shock, and impaired vasomotor control due to our anesthetic drugs. Anesthesia already causes vasodilation and impaired thermoregulatory control, and the operation theater is already cold. And as the patient was undergoing laparotomy, there was open cavity and evaporation and heat loss was there. And unwound IV fluids and blood components further decrease the core temperature. Evidence-based patient warming. Uh, the devices which are evidence-based are forced air warmers, which we routinely use in our OTs. They have thermostat and they can be controlled. The temperature setting is there. There are conductive electric resistive blankets which are made of carbon fibers and resistive wire elements. They also have thermostat. Conductive mattresses are also there. There is no direct skin contact and the warm water is circulating through the mattress. There are fluid and blood warmers and radiant warmers. The radiant warmers are usually not used because uh, in our OTs they are used in neonatal care. Improvised warming methods. What are the reasons that we improvise some of the warming methods in our OT? Because there is unavailability of devices and the audit has not been done which device is functional or not. In emergency out of our procedure or equipment malfunction and absence of institutional policies and SOPs. What are the common improvised methods? There are water-filled gloves, hot IV fluid bottles, hot water bottles, warm towels, and rice bags. So the risk ranking, the water-filled glove, IV bottle, and hot water bottle are not at all suggested because they do not have any temperature control or thermostat. Microwave gel pack causes uneven heating and only it cannot be used thus. Warm towels and rice bags have lower peak heat, but still these are not validated. Why do burns occur? The burns occur because there is a sustained pressure at the device contact point. The heat is unregulated, which is transferred to the skin directly. And the duration of uninterrupted contact also plays a vital role, because if it is for a longer time, the burn is inevitable. The impaired perfusion in sick patients and which are already in shock and vasopressure, and reduced sensation due to anesthesia. The patient is unable to move or protect. There is no pain response. Coming to the review of literature, there is a closed claim analysis. It was published in Anesthesiology in 1994. It was done by Cheney and et al. They found that burns from warming devices in anesthesia, they reviewed 64 claims. Mostly they were warming device related, and delayed recognition was common in all of them. So, but the system failures were preventable. The key takeaway is that warming device burns have been documented in formal liability analysis for over 3 decades, and this is a known hazard and not an unforeseeable accident. There is another review which was published in Wounds by Kornhaber et al. It was an integrative review which also found that common causes were forced air misuse, hot water bottles, and improvised devices. Risk factors were similar as in our case, like elderly, diabetic patients, shock, and long OT durations, which impaired perfusion and sensation. Reduced patient sensation like anesthesia, neuropathy, sedation, and critical illness also caused this. So they called for standardized device protocols and clinical clinical analysis. The common thread across all of them was every device type reviewed, injury occurred where heat was unregulated and the patient could not physiologically or situationally react to it. Mechanism of contact burns. So Moritz and Henrik's time temperature relationship describes the mechanism. At 44 degrees C, sustained contact for more than 6 hours can cause injury. At 50 degrees Celsius, injury becomes inevitable within minutes of contact. At 60 degrees C, injury becomes within seconds of contact, and at 70 degrees Celsius, the injury is within a second. Why a water-filled glove is mechanistically dangerous? Because there is no thermostat and the concentrated contact area is concentrated at one point. So coming to the point, could this have been prevented? So the answer is yes. I believe because not one individual made a mistake, but because several safety barriers failed simultaneously. That's exactly new few slides will explore. Coming to the root cause and human factors analysis, each layer of defense has gaps. Harm only occurs when gaps in every layer align. So the failure was in equipment. The equipment was not validated. There was no communication or a structured handover. Staffing was not adequate because there were other calls for the anesthetist. There was no supervision as handover was not given and no individual was assigned for the case. Uh, the anesthetist was fatigued and out of hour conditions were there. Environment, theater was resource limited. So this is explained by the Swiss cheese model. Many failures lead to the accident. So the trajectory is completed. Coming to the fishbone diagram, mapping the causal categories that converge to produce this incident. Again, limited staff, equipment, methods, and environment. Communication was not there and there was no SOP or institutional policy. So these causes led to the effect of burn. So what went wrong? In our case, commercial warmer was unavailable. Improvised glove was used. The patient was not monitored, and communication failure was there because nobody was given the handover, and a thermal burn that was preventable was the outcome. So what were the risks to this patient? The patient was already in septic shock. There was hypoperfusion. Vasopressors must have been there. The patient was under general anesthesia. Their surgery was emergency one and procedure was long. There was no monitoring of the temperature. All this led to all these 7 factors led to the incident, and the patient was already in high risk. Coming to the guidelines, the ASA suggests temperature must be monitored where there is significant hypothermia is anticipated. NICE guidelines of UK suggest pre-warming of the patient and continuous core temperature monitoring for at-risk surgical patients. WHO safe surgery, there has been recommendation from various groups to incorporate the patient temperature item into the surgical safety checklist. ERAS protocol already uses normothermia as a core perioperative care bundle element. So we have to use active warming, core temperature should be monitored and shared. These have been shared recommendation to maintain temperature above 36 degrees Celsius. So where and how to monitor the temperature? Coming to the core sites, distal esophagus, nasopharynx, pulmonary artery, and bladder, they are reflecting the true core temperature. They must be monitored in at-risk and prolonged cases. Near core or convenient sites are axilla, rectum. They have reasonable accuracy, and zero heat flux skin sensors can be placed non-invasively. Peripheral sites like skin and tympanic membrane are least reliable. So what should be the correct setup? Select the correct blanket by forced air warmers, and blanket size and shape should be correct. Connect the hose of the warmer to the blanket only and not directly to the patient. And blanket should cover the patient fully without any fold. Set the blanket, monitor the temperature and reassess every 15 to 20 minutes. What are the prevention strategies? The temperature should be monitored, warmer should be approved, not like improvised ones. Reassess every 15 minutes, protect the skin at point of contact. Documentation should be there of the warming device. Handover should be proper. So what is the APSF recommendations? Safe warming practice. Use only validated manufacturer approved active warming devices. Devices should be inspected and audit should be done, and avoid direct contact between the device and skin. There should be reassessment and documentation. Continuous reassessment, recheck the contact site and documentation, record device type and monitor responsibly. Prevention bundle of roles and responsibilities. What are the roles of anesthetist? Anesthetist should use a validated device, monitor temperature and document the use. Nursing teams should inspect skin at the contact site. Biomedical should maintain and inspect the devices and ensure backup units are there. Department and institution should set the policy and SOP for the institute. So what is the proposed institutional SOP? If you detect hypothermia, there should be a commercial warmer available. If it is available, then use the approved device. If it is not available, then escalate the matter to seniors and monitor continuous and document. And if there is any incident, it should be reported. So coming to the summary, key messages, I would like to leave you with one final thought. Hypothermia is common, and warming patients is an essential part of good anesthetic practice. But every warming intervention carries responsibility. The difference between safe warming and patient harm is rarely the temperature itself. It is presence of monitoring, communication, and accountability. Our patients deserve better. Our patients deserve warmth without burns, safety without shortcuts, and evidence without assumptions. These are my references. We are open for discussion.
Thank you so much, Dr. Atul. I think you highlighted some very important points. I think the most important being is whatever is the warming device that you use, always make sure it's not in direct contact to the skin. Even if it's a forced air warmer, I think we have a huge problem in using forced air warmers in the OT, in the sense that the blankets that come with the warming systems, they can get soiled or wet, and that's thereby they can't be reused regularly. So usually we have to use two sheets, that is provided by the hospital, the cotton sheets. And a lot of the times they forget you have to put a layer over the patient, put the warmer, and then put another layer of blanket so that the forced air also is not, in direct contact to the skin of the patients, because that's what can cause the burns. Hetal sir, would you like to add something to this?
It was a wonderful presentation, Dr. Atul. As Archana said, we are using same, like this commercially available sheets are costly, so we have prepared this similar kind of things and we are using it, but they are a bit safer. This presentation made me remind of incidents which happened at our hospital roughly 10 years back. At that time, we had room warmers in our recovery area. In operation theater, we had a good warmer, but in recovery area, we had room warmer. One patient had post-op shivering, and recovery nurse asked junior nurse to keep the warmer. Patient was under spinal anesthesia, and she put the warmer close to the lower limb. And unfortunately, patient had burns. Luckily, we could explain the things, and patient's relative were good. Otherwise, it could have create big problem. So the things, you should have protocols. You have to monitor the things, and you have to be very vigilant while using all of these warming devices. That should be the message. Thank you, Dr. Atul.
Thanks. And another one is when we use fluid warmers. That's another, active warming technique that we use. Sometimes when you don't have the fluid warmer, I mean, I've seen this in certain places. Even it's happened to us once in my previous institution, where they get a hot saline and then they put the tubings through the, into the saline, and then it goes to the patient. So what has actually happened is it was so hot that along the course of the vein, there were actually blebs that started to form. And, when the patient's under the drapes, it becomes very, you see after surgery, and it's a very scary sight to see. So we should be very careful with fluid warmers as well. Rather than checking the warming status or the temperature at the start or before the warming device, you should always check it before it's entering the patient to make sure that the temperature is appropriate. It's not too hot. Even cold is all right, we can manage it, but too hot makes things quite a bit problem. Murli sir, would you like to add anything else?
Yeah. So regarding the hypothermia, when you look at the data, right, and also the articles which are there, there's a lot of work done by the Stanford team with regards to the hypothermia. And one of the things that they noted is we generally take care in the very young, the very elderly, and the longer duration surgeries. So these are areas where we as anesthetists generally tend to take care. You see an infant coming in, everybody is worried about AC being on and the warmer being on before the child comes. And if it's an elderly, again, we are taking care. But the ones who end up becoming hypothermic are the ones who undergo surgeries of 1 to 1.5 to 2 hours duration. And these are the areas where, especially if you have a JCI or NABH accredited operation theater, you will have these ACs running at 18 degrees with laminar flow. And under laminar flow, it is much cooler because of the air flows. And then you end up with the patient who is hypothermic. So this is something which we need to keep in mind, that we generally neglect these patients who are invariably the ASA1, 2, the fitter group, which undergo for 1 to 2 hour duration. Coming to the warming devices and Atul's presentation, it was extremely detailed, and I would love to actually listen to it once again, because he had so many wonderful points in that. Both the presentations today, they were so nicely flowing and wonderfully presented. The thing about causing damage, I had never seen that slide of the temperature and the contact time. That was something very new to me. So the 44 degrees, minutes, or the 60 degrees seconds, and then the 70 degrees. This is very important because if you look at the any device which warms, let us take a fluid warming device, it doesn't heat that fluid more than 40 degrees, 41 degrees maximum. The reason is it causes the red cell lysis if it enters immediately, or if you're sending the packed cell through it, it causes lysis of the red cell. Second, the neural structures are very sensitive. Please remember, when we do as chronic pain physicians, neuroablation techniques like the RF ablation, anything above 42 degrees can cause permanent nerve damage. So the pulse radio frequency treatment that we do for any kind of neuralgias like trigeminal or any other conditions, we don't go above 42. Anything above 42 can cause neurolysis. So imagine a glove filled with hot water on the patient is actually burning the nerves on the top. Forget the skin, it's causing burns. So the patient, even if the skin is intact, can have a grade 1 burn and have severe burning pain, and also can lead to severe neuropathic pain later. So these are the points, and of course, everything else was highlighted. I don't want to kind of talk about any anecdotes because everybody will have anecdotes. We will listen to other senior people here. Dr. Champa has joined us from Shivamogga. She, in fact, is the organizing secretary for the upcoming Obstetric Anesthesia Conference, National Conference in Shivamogga in October 30th onwards. So, Dr. Champa, would you like to say anything regarding this? I think I'm asking questions without warning them that they might ask them. So, anybody else would like to add anything? Dheeraj or I know there are a lot of senior people here in the.
Murli, can I add something here?
Yes, sir. Please, sir. Please, sir. Please.
Yeah. First of all, I would like to congratulate Dr. Atul for a detailed, informative presentation. I remember one incident long ago when it was very labor epidural were not very common. I had put an epidural for the one patient in a nursing home where it was very, very new. The method was very new. And I had given a supplementary dose just before about 5-10 minutes before the delivery of the patient. Immediately after the delivery of the child, patient started having shivering, that is postpartum shivering. And as usual, there were no warming devices. A hot water bottle was put on the lower abdomen, and the temperature was high. Because of the epidural effect was still there, patient could not feel the temperature, and she had burns. As usual, it was difficult to explain, and somehow it was explained. What I want to highlight here is, it is not only in an unconscious patient, even a conscious patient can undergo the burns. We have to be these younger patients and who has just had a delivery, we have to be extremely conscious and vigilant in these patients. Just as Dr. Hetal has explained, in a spinal patient, here it was just a delivery and patient was conscious, patient was able to move also, but the burn happened. We have to be eternal vigilance is the warning here. Thank you.
Thank you, sir. Thank you.
Murli sir, thank you. Thank you for
Champa,
that.
you're back.
I had some. Yeah. Good evening, everyone.
Good evening.
Wonderful discussion happening. I would like to share a few modifications we have done in our government hospital. Initially, we were using the blower, and in an infant, we ended up burning the heels. So now we are equipped with bear hugger, which actually gives a controlled warming of the patient. We have bear huggers in the government setup for adults as well as pediatrics. In adults, it becomes little cumbersome to maintain the patient on the OT table. But for the pediatric, I feel we are finding it very useful because the surgeons wouldn't let us switch off the AC, how much ever we tell. And if you at the times the surgeon even tried operating under a warmer, like the neonatal warmer we have in the NICUs. But that was very uncomfortable for both surgeons, anesthesiologists, everybody. So now we are equipped with bear huggers that are really doing wonderful things for us, especially in maintaining the body temperature. Definitely prevents hypothermia. Thank you.
Thank you, Dr. Champa. Again, I would like to highlight a few things here. One is perfusion of the patient. If the patient perfusion at the skin level, like a septic patient, a patient who is sick, is less, they're more prone for burn injuries. One. Second, your pulse oximeter can cause burns. So my first case report, which I published, was a burn from a pulse oximeter. So the reflectance pulse oximeters, which are used for neonates, they're actually put on the forehead in adults. If you're not able to pick up a saturation, if it's a poor perfusion, somebody's on vasopressin and there is no perfusion happening. So this was a patient who had a reflectance pulse oximeter. What we use normally is transmittance pulse oximetry. And that patient had a proper burn on the forehead because it was not moved. So you please have to remember that patients are at a risk of burns, whatever precautions we take. And both the incidents today have highlighted something looks very trivial, right? Tourniquet looks very trivial, warmer looks very trivial, but can cause something which can have lasting effects. We are in a system where for our, I would say, lack of maturity of the system, the medico-legal issues are not that high. But if you were to be in a system where medico-legal issues can happen for such incidents, trust me, there will be a lot of cases coming up against not only anesthetists, but surgeons, because such trivial incidents can cause lasting morbidity. So this is something that I would like to highlight. Anything else, if anybody has got to add? Otherwise, we'll go ahead with what Abdul had suggested earlier, that all of us would have faced the last 15 days, some small incident or heard about a small incident. We recently heard about this major crisis happening in Hyderabad, and we are still waiting for confirmation regarding the inquiry. We will discuss that another day. But if you have come across anything small, anything that has happened, small reaction, anything, we would take the next 5 minutes after we end the meeting. I request all of you to just open your phones up. It'll take you just, I'm still in the election mode probably to tell about voting, but it's not about voting. It's about reporting now. So kindly report incident that you come across. As all of you know, it's completely anonymous. We have now 160 plus incidents in the last 4 months. We'll be presenting the data in the upcoming APSA conference in Coimbatore. So kindly request all of you to just report one incident and let us test the servers. That is my take-home message today. Anything else, Archana?
No, I think we've pretty much covered everything. Thank you so much, everyone. And to update,
Sorry to disturb. Can I ask you one question? Just
Sure,
for
Dr.
basic.
Yes, Dr. Alpa, yeah.
please.
Actually, when there is a shivering and we start with some medications for shivering. So what is the take on that? Like there are some drugs which are treatment for which are recommended for treatment of shivering. Is it okay to use that drugs when like even if you give fluid warmers or blanket, then also some patients have shivering. What is
Murali,
your take on that?
you want to take it or shall I?
You can, or Dr. Atul has read quite a lot, so let us see if Dr. Atul has gotten new answers for us.
Good.
So ensuring that the patient is warm, and after that, even that there is shivering, meperidine can be used. But you have to first ensure that everything you have done for the warming of the patient.
Yeah. So that's the number one. It's first you ensure active warming, whichever way is possible, and the blanket, of course. And then if it comes to medications beyond that, yes, pethidine is one such medication you can use. If it's not available, then yes, as an alternative, we do use tramadol. 50 milligrams if in an adult, and that is also recommended for reducing the threshold for, or increasing, I should say, the threshold for shivering. So it is used, and I think it is recommended. Is it not, Murli sir?
Yeah, in fact, that is what probably people use. Yeah.
Yeah. Okay. So active warming is the first line. Second line is medications, if just to supplement that, and of course oxygen supplementation to reduce the, to supplement for the demand in oxygen because of the shivering. Is that okay, Dr. Alpa?
Yes, yes. Thank you, ma'am.
Yes.
And ma'am, any take on like when there is a when you have a core temperature is less, and if you are using body warmers, like is there any concept like it will cause more hypothermia if you don't treat the core temperature already is the core temperature is less and you are using the body warmer on the surface. Is there any concept like that? It may happen that it will cause more decrease in core temperature like that.
No,
Somebody
Dr.
told
Alpa. In
me.
fact, no. In fact, see, the thing with anesthesia is there is redistribution of the blood from the core to the periphery, and that's the reason your temperature drops because of radiation. So the mnemonic that I tell the juniors to remember is RACER. So radiation is the first way you lose heat. Then comes your convection, then evaporation, then last is conduction, basically. So if you are having a patient under a regional and a GS, so let's say you have an epidural and GA, the loss will be further accentuated. So the main thing is it is actually coming out to the periphery and then it is getting radiated. So a forced air warmer is preventing this radiative loss, which is actually the maximum loss when it comes to the temperature. So it won't drop the core temperature or anything like that. If the core temperature is already low, you might have to keep the forced air warmer for a longer time. And the best way to increase the core temperature is to give warm IV fluids because you're directly going into the core. So that would be the best way of warming if you're actually warming a core temperature. But the forced air warmer is preventing the loss of that radiation element of heat loss.
Yeah. Okay. Thank you, sir.
Thank you. Dr. Alpa, where are you from? Sorry, you didn't introduce. I just wanted to know.
Sir, I'm from Jagjivanram Railway Hospital. I'm in Mumbai Central. I'm working there as a consultant.
Thank you. Thank you.
Yeah. So it's like fluid warming as such. And then also core temperature wise, if it's surgery related, like you're having you usually have this in laparotomies. In that case, you ask the fluids that they're using for irrigation or even for the wash, or the mops that they use, that also can be, warm saline. So that will also prevent your loss of core temperature during surgery as well. So that's
Ma'am, that temperature, that warming fluids, like how to control that temperature of that fluid, no, when you are irrigating, no. So
it's
how
the
to check that temperature?
So we won't check that. We'll have to ask the staff nurses or the surgeon before they go inside. They'll have the same warmed fluids that we have. So we have a warming fluid cabinet wherein, it's maintained at a temperature for the whole day. And then the fluids are taken for the surgery side or even for us from the cabinet itself. So, it's not from the open air, or even previously they used to put it in through hot water, something like that, to warm up the fluids. So usually the irrigation and all those fluids also, you should try to keep it warm, from the active surgery side. So that also prevents your core from, losing heat.
So that cabinets are commercially available, like they supply like that, because I have not heard of this thing. So I will try for that. Okay. Thank you, ma'am.
So that is, Dr. Alpa, that is one way of warming the fluid. You have the commercially available, which is set at say 30, 32 degrees or 35 degrees, and it's not more than 37. But we also use microwave in certain conditions. Say when we do a whole lung lavage, we don't want to be sending, we do a lot of whole lung lavages at our center. So we don't send the cold fluid in. So we have done a small study looking at what is the temperature of fluid after 30 seconds in microwave, 40 seconds in microwave, like that. So at around 40-45 is a sweet spot if you have a normal fluid bag, which warms the fluid to around 25 to 30 degrees, which is definitely better than the normal room temperature in the AC area, which might be around 19 to 20. So you can use whatever is available to you. Make sure you can use that with a little safety inbuilt into it.
Okay,
And
thank you. Thank you.
thank you. And there was a question here: how do we subscribe for APSA newsletter by Dr. Amola Parikh? We are actually going to be uploading all the newsletters to the website. The website team, I think many of the ambassadors here are there. So they're developing the website. So it will be available on the website for download. Right now, we are sharing it through WhatsApp channel to various people. So I think in a month's time, we should have the website up and running with all the newsletters available for download.
Okay, thank you so much, sir. And I really do hope everyone logs in or subscribes to the Docked app and helps us out by testing it today and also giving us more opportunities and experiences to discuss about. With that, if it's okay and everyone, there's nothing else to add. Murli sir, shall I close this meeting today?
Yes, please.
Thank you so much to our speakers for your very enthusiastic speech. And also thank you, Dr. Hetal and Dr. Kumaraswamy sir, and of course, Dr. Champa and all the other seniors that have attended here today and made this very experiential learning for all of us today. Thank you so very much. And Murli sir, all the best to you. And thank you very much.
Thank you. Thank you. Thanks a lot.
Thank you, Murli.
Thank you. Good night. Good night, Hetal. Thank you.
Thank you, sir.
Good night. Good
Good
night.
night.
Thank
Thank you, sir. Thank you very much.
Good night.